Thank you very much. My name is Bansri. I'm very happy to be here on behalf of our team. My colleague Ashley, who has contributed significantly to the project, is also here in the audience. Okay, thanks. It's an audit that we have done. I'm going to be presenting the data from the Midlands, from the East and the West Midlands, and this audit has been done as part of a nationwide multi-centre project that was undertaken by the UK ARCOG in the month of September 2014. Over the next few minutes, I will talk a little bit about what UK ARCOG and MROG stand for, talk briefly about how the National Primary PPH Audit came about, how it was designed, and the methodology, but I'm going to concentrate mainly on our audit findings from our region in the East and West Midlands. So UK ARCOG stands for UK Audit and Research Collaborative in Obstetrics and Gynecology. It's a network of trainees across the UK, and the reason it all sort of came about was for the trainees to undertake large-scale national multi-centre projects to come up with powerful results which would help bring about change and improve patient care. It would also help us get a large number of local and national data, which would again help improve local practice across the regions. MROG stands for Midlands Research Collaborative. The East Midlands Trainees Collaborative was formed in April 2014, and the West Midlands Trainees Collaborative had been going for about a year before that. In October last year, we joined hands and became the Midlands Research Collaborative, and we are very thankful for the support and encouragement we have received from the BMOGs. To talk a little bit about the National PPH Audit, this was a prospective national multi-centre audit conducted in 2014 for the whole month. Different deaneries took part, and we as the Midlands team were the second highest contributor in the whole country in terms of data, only second to Scotland. It's the first audit of the kind undertaken by the National Collaborative in Obs and Gynae, and it has helped us gather a large number of national and local regional data for analysis and to improve our practices. And the aim was to compare the national practice in the prevention of and management of PPH to the UK RCOG Green Top guidance. So 98 centres across the country participated, which is 48% of all units in the country, so good coverage for a first project. 190 trainees in all those centres contributed to the project in some way or another. As I said, it was undertaken in the month of September, and we collected data from 3,647 women across the country who suffered primary postpartum hemorrhage. It was a prospective audit, like I said, and we included all women who had vaginal deliveries and bled more than 500 mils, and all cesarean deliveries where the blood loss was estimated to be a litre or more. And all patients that were managed in an obstetric unit were included, so all people who delivered at home but then had to be brought in for hemorrhage management were included in the study as well. Methodology, we collected a large number of data, so we looked at risk factors, a bit of demographic information, risk factors for postpartum hemorrhages, whether we're offering active management of third stage of labour to all our women, whether they've been giving active management. We looked a bit at the onset and mode of delivery and how this was related to postpartum hemorrhages, how the women were being resuscitated, the order in which the uterotonic drugs were used in the treatment of postpartum hemorrhages, and seen if there was adequate senior involvement. For the purposes of this presentation, I'm going to concentrate mainly on the data highlighted in red. So these are the audit standards, some of the audit standards which we have compared our data to, and these are taken from the National RCOG guidance. So the national guidance, it's not completely easy to use all the guidance from the RCOG because it involves lots of different centres, and all the different units will have their own regional protocols and policies. So RCOG states that all women with low antenatal haemoglobin should be investigated and treated appropriately. All women should be offered active management of third stage of labour. Women who have a primary ppH of 1 liter or more should have full protocol of measures in place for resuscitation and to achieve hemostasis. Any woman who bleeds more than 500 mils should have a Crystallod infusion initiated, even if there are no clinical signs of shock. And all patients with a postpartum hemorrhage, which is blood loss of 500 mils or more, should have physiological parameters recorded on a flow chart for recognition of patients that are becoming unwell. Concentrating now on the audit findings from the Midlands. So over the month of September, we had 7,417 deliveries in the participating centres, and that's 14 units across the Midlands. 979 of those patients had a primary postpartum hemorrhage, giving us an incidence of 13.2% in the month of September 2014. We collected data from 879 patients. Looking at the chart on your left-hand side, the blue bars indicate the regional data, and looking at that, majority of patients had blood loss less than 1 liter, 37.7% had blood loss ranging 1 to 2 liters, and the remaining patients had high blood losses. This is mirrored by the national data, which is the bars highlighted in pink there, similar sort of percentages. Talking a bit about the demographics, the average maternal age at booking of the pregnancy for our regional data, 29.6 years. The national average was 29.4 years. Average maternal BMI at booking 26.7, whereas the national was 26.6. Looking at the chart in the blue on the left, we can see that more than half, about 58.6% of patients fell in the BMI 25 or more, so obese category. 7.4% were grand multip, so para 4 or more, and majority of the pregnancies in the study were singleton pregnancies. Just looking at onset of labor, so 796 patients out of the 879 definitely labored. The remaining had elective cesarean sections. Out of those women who labored, the majority of the women who had spontaneous delivery had blood loss less than 1 liter. Majority of women who had induction of labor had blood loss of less than 1 liter. It is also interesting that we noted that quite a significant proportion of women had prolonged labor lasting more than 12 hours. Looking at the mode of delivery and the blood loss, majority of women who had spontaneous vaginal deliveries or instrumental vaginal deliveries had blood loss less than 1 liter. We did not include women who had cesarean sections and bled less than 1 liter in the study. We only included women who had blood loss of more than 1 liter with a cesarean delivery, and majority of women bled between 1 and 2 liters after a cesarean delivery. Going through these standards individually now, some quite interesting findings. So the RCOG guidance states that women who have hemoglobin less than 9 grams per deciliter are significant risk of bleeding postpartum, and all these women should have antenatal investigations and be treated. In our group of women, 3.6% had anemia detected antenatally, so that is hemoglobin level of less than 9 grams per deciliter, but only 34% of these patients received iron replacement. We didn't collect data about whether these women had appropriate investigations done antenatally, but not everyone had appropriate iron replacement. We're doing quite well in this area, looking at the active management of third stage. So out of the total number of patients, 96.2%, which is a number in the middle, were offered active management of third stage. And of those 846 patients, 836 actually received active management of third stage. Of those 10 patients which were offered active management and consented to it but didn't receive it, 3 patients delivered before we could get to them at home. One patient actually changed her mind and declined. There is no documentation for reasons for why other patients didn't receive active management. Small proportion, 1.6% patients, there was no documentation in the notes as to whether they were offered active management of third stage or not. However, the implementation of the active management of third stage is quite varied across the regions. Majority of patients, so that is 58.6 majority of patients, so 41.8, which is these two on the right side, received syntocinon boluses. 41.5% received symptometrin. A small proportion, 3.1%, it just said other in the notes. Looking through the data, most of them, it looks like they had syntocinon infusion running straight after delivery of the baby. Quite interesting. Quite a significant proportion of patients with hypertensive disease were actually given symptometrin for active management of third stage, which is something that we definitely need to look at for improving practice. In terms of measures for resuscitation, the RCOG recommends that patients who have major postpartum hemorrhages should have a number of measures in place for resuscitation. We have looked at three things, three sort of quite basic but very important measures. So it states that these women should have 2 large bore intravenous access, they should have urethral catheterization and have intravenous fluid resuscitation. We found that of the 409 patients that had blood loss in excess of a liter, only about 273 patients, that's 66.7%, didn't have these three things. So they either didn't have 2 intravenous access, didn't have adequate fluid replacement, or didn't have urinary catheterization. And about 21, so again, quite a significant number of these 273 women actually had blood loss of 2 liters or more, and despite that, didn't have those measures in place. Resuscitation with crystalloid for women who have blood loss of 500 mils or more. Again, 19.8%, so almost 20% of women with blood loss of more than 500 mils did not have documented evidence of fluid resuscitation. And again, quite 30 out of those 173 patients had major significant PPH and didn't have any IV fluids at all. Talking a little bit about the order of uterotonics, again, this is quite difficult to look at because a lot of units have syntocinon infusion set up to start as soon as the baby is delivered, and women with risk factors. So it's something that we struggle to look at data-wise, but this is the order in which the RCOG recommends that we should be giving uterotonics in the treatment of postpartum hemorrhages. Looking through the data, we found that majority of patients were given uterotonics in appropriate order. However, ergometrin is significantly underutilized, and misoprostol, again, is often given before carboprost. And almost 30% of patients, this was a problem. So they either had a bolus of syntocinon, symptometrin, then went straight to misoprostol, or straight to carboprost without trying ergometrin, syntocinon infusion. So, and all of these patients that missed ergometrin in the protocol, there was no documented evidence of hypertensive disease, which would contraindicate the use of ergometrin. This is not something in the RCOG guidance, but from having worked in the units that I have worked in, from talking to other colleagues, it is quite routine practice to be giving prophylactic syntocinon infusion to women who are at risk of PPHs. And in our group of women, we found that 86% of women had at least one or more risk factors for having a primary PPH, but only 24.2% received prophylactic syntocinon infusion. A significant proportion of patients with blood loss of more than 500 mils didn't receive any additional uterotonics apart from the drug used for active management of third stage. And of these, 48%, so again, quite a significant number of patients actually had blood loss in excess of a liter, and despite that, didn't receive any additional uterotonics apart from the drug bolus used for active management of third stage. A little bit about the recording of the observations following in women who have postpartum hemorrhages. Again, we're doing quite well, but significant room for improvement. Majority of women, so almost 79%, had observations recorded on mouse charts for identification and monitoring of women who are unwell. In terms of senior involvement, we noted that consultant obstetrician was involved in 27.4% of all cases, all patients who had PPHs. When patients had blood loss in excess of 2 liters, Consultant obstetrician was involved in management in 70% of those patients. Consultant anesthetist, again, in patients who had blood loss in excess of 2 liters, there was involvement in 50% cases where a consultant anesthetist was involved. Of all the women, 28 patients were admitted to intensive care unit, majority for postpartum hemorrhage, 1 patient for significant preeclampsia, although in 5 of those patients, there was no documented consultant input. Now, it's very unlikely that the consultants weren't involved for someone going to intensive care unit, but we couldn't find any documentation in the notes that this had been done. There are, of course, limitations to the study. It is the first national project of the kind that we have undertaken as trainees. As I said at the beginning, it was difficult to set standards as there is significant variation in regional practice and policies. Large number of trainees collecting data, and when it came to the analysis stage, we noticed there might have been some problems with the way different trainees have interpreted the questions. For example, the question about the involvement of the consultants. Do you consider phoning a consultant as an involvement, or do you consider a consultant physically being present, managing the patient as involvement? So these are the areas that we have identified which could have potentially created issues. So to conclude the talk, we have shown that we can work together as trainees and come up with some meaningful results by undertaking large multi-center projects. We have indeed learned some lessons. We have learned that the incidence of PPH in the Midlands in 2014 was 13.2%. We are doing quite well with offering and giving patients active management at 3rd stage of labor, although there is large variation in regional practice. We have identified a number of areas for improvement. Treatment of antenatal anemia is one of the important things. 15% of patients with hypertensive disease were given ergometrin or symptometrin, and these are women at risk of stroke, so something that we need to bear in mind. IV fluid resuscitation, again, as we saw from the data, not adequate, even in some women who have had blood loss in excess of 1 liter, not being given any IV fluids. Just wanted to bring that up as a discussion with the group as to whether we need to have standardization in the order of uterotonics we use, although there is a wide variation in local practice, and whether we would recommend increasing the use of prophylactic syntocin infusion in women who are at risk, although this is not in the national guidelines currently, and improvement in consultant involvement, involving the consultant seniors early when women have had significant blood losses. Thank you very much for all your attention. I would like to thank the whole team of trainees that was involved in putting the project together and coming up with the presentation. Thank you to Ashley in the audience. Thank you.